discuss your recommended improvements to IPAB. You mentioned in your testimony that flexibility should be provided to help recruit high-quality board candidates. Do you believe then that under the current statute, the board will be unable or will be able to recruit high candidates?
Congressman Dingell, thank you for the question. I don't believe the way it's currently constructed, the IPAB will recruit the kind of people that we want. First of all, the IPAB membership is a full-time, if you will, occupation. It means that we can't bring in the best and the brightest from throughout the health sector with various perspectives to help guide this process. We're almost destined with that approach to bring in retired people.
My next question is you've gotten a bit ahead, but one, what will be the barriers to recruiting candidates? And two, what should we do to eliminate those barriers to enable us to recruit the strongest candidates?
My guess is that the importance of this process is that there's some excellent candidates may come to serve just with their expenses covered. But I think that this shouldn't have to be a full-time commitment on the part of those individuals. We need people who are the best and the brightest in the healthcare sector, who understand the economics as well as the clinical realities of this and the patient perspective part of this, to be sitting at around this table. So I think that the way it's designed in terms of the pay and the requirement that it be a full-time occupation will make it very untenable.
Okay, now, Doctor, IPAB establishes a consumer advisory council to advise the board on how payment policies impact consumers. However, this is an advisory capacity only and does not include patient representation. Now, as a physician, how would you recommend addressing this problem and encouraging patients' participation to help in decision-making necessary for the board to issue the best recommendations?
Well, I think the IPAB ought to have patient representation sitting right there on the board itself, if it was to exist. Patient representation should have been part of the process of the IPAB. But I would say, Congressman Dingell, that I think we have to reconstruct what we consider this IPAB model if we wanted to actually achieve cost containment over time by systematic improving quality of care. I think the way it's designed isn't going to work. So I'm not so concerned about how we get the members on it right now. I'd like to see a design of a system that might actually reduce costs and improve quality.
I notice you, Dr. Velasquez, were nodding yes.
Yes, I agree completely. It seems like we've gotten a little bit ahead of the conversation. We're talking about how to structure IPAB and how it should be set up with advisory committees. But I think a more fundamental question is really, will it achieve the aims it sets out to do without creating too many adverse events like limiting access to care for our seniors?
Thank you. Now, again, coming back to our first witness here, your testimony suggests the use of data registries is one way to ensure high-quality care while identifying areas to reduce spending. In particular, Doctor, you mentioned the ACC's Pinnacle Outpatient Registry. I happen to believe that the technology advances like electronic health records and registries can create savings, but I also know that there can be a resistance to implementing such technologies. How many providers participate in this registry currently, Dr. Lewin?
Thank you for that question, Congressman Dingell. Nearly all the major hospitals in the United States participate in the registries, and they pay us for the data, and that allows us to actually keep this very expensive operation going. In the physician outpatient setting, it's really hard to ask the doctors to pay us for a collection of data at this time. But 1,000 practices have signed up. We have 2 million patient records already with this relatively new system, and we can see measured improvement in quality across the entire Pinnacle network. I might add that 100% of the Pinnacle participants received the full PQRS reward and the e-prescribing reward, and we were able to file for them. So there is some small reward, but if we were to use payment reform to provide real incentives for improved outcomes and quality, This would go rapidly across the entire environment. It needs to reach to internal medicine and family practice and others who share in the care of cardiology patients with us in the outpatient setting.
My time is up, Doctor, but I'm with the patients as a chair. I'm going to ask you, can you give me an example of how a member of ACC has used a registry to bring down the costs of their practice?
Absolutely. The one thing I can give you is that they got an average of $8,000 to $10,000 back from the rather pitifully small reward program called PQRS that Medicare uses today by participating in the registry. They got rewards from Bridges to Excellence and from other employer-based private insurance approaches. And some of them are now going to receive a bypass of having to go through call a nurse to get permission for a procedure, because they can demonstrate to the insurance company that they're making the right decisions using the clinical decision support tools embedded in the registry. So it's a hassle factor improvement for the doctor, and time is worth money. So even though the payment incentives aren't really aligned yet to improve quality, even now this Pinnacle registry is offering some benefits to people in the current environment.
Thank you, Doctor. Thank you, Mr. Chairman.
Chair, thanks to gentlemen. We are voting on the floor. We have 11 minutes to go. We have time for